Imagine you step into a doctor's office. Right. You tell them your arm is hurting, and they take an x-ray.
Standard procedure.
Yeah. And the doctor looks at the film, points to this jagged white line, and says, there it is, a fracture.
Right. It's objective.
Exactly. It's precise. It's basically engineering. But now imagine you walk into 3 different doctors' offices, you say you're feeling profoundly tired, and they give you 3 completely different diseases.
Oh, wow. Yeah.
I mean, in physical medicine, that sounds like a massive malpractice suit waiting to happen.
Huh?
But in the history of psychology, that used to just be a standard Tuesday. Welcome to the psychology undergrad.
It is the absolute definition of diagnostic muddy waters. And we are so thrilled you're joining our study session today to help us wade through them.
We are taking a deep dive into our clinical psychology textbook readings for the week. We're going to share our notes, cut through all that dense academic jargon, and really figure out how mental health professionals actually measure and categorize human behavior.
Because the mission here is to answer this fundamentally difficult question, which is, how do we actually know someone has a psychological disorder? And, who gets to write the rules?
Right.
Because as we'll see, those rules are constantly shifting.
Yeah, they really are. But before we can even talk about diagnosing a patient or handing out labels, we have to talk about the tools themselves.
Definitely. The foundations.
Right. If you're going to measure someone's mental state, you have to know if your measuring stick is actually, functioning. Which brings us to the 2 giant pillars of psychometrics, reliability and validity.
The essential rules of measurement. I mean, without them, any test you give a patient is functionally useless.
Yeah.
It's just noise.
Yeah. And to help us keep these straight for the exam, I like to use a couple of memory tricks. So for reliability, think repeatability.
Okay, I like that.
Imagine you have a broken bathroom scale. Every single time you step on it, it tells you that you weigh 500 pounds. You step off, step back on 500 pounds. Tomorrow, 500 pounds.
So that scale is highly reliable.
Exactly. It is incredibly consistent. But for validity, the memory trick is veracity, or thinking of a bullseye.
Right. Does the scale actually measure your true weight? Is it telling the truth?
Yes. And in the case of our 500-pound scale, the validity is 0. It is consistently wrong.
Okay, let's unpack this. So you can have a test that is completely reliable, but entirely invalid.
Yeah. That's the exact trap a lot of early psychological tests fell into. Consistency does not equal accuracy.
Wow.
Yeah. And the textbook breaks reliability down into a few different mechanics that we need to understand. First is retest reliability.
Which is pretty self-explanatory, right?
Basically, yeah. If you take an IQ test on Tuesday and then take it again 3 weeks later, you should get roughly the same score. The assumption is that your underlying intelligence didn't just suddenly transform over a long weekend.
Right, but wait. What if someone just memorizes the questions from Tuesday, though? Wouldn't their score shoot up the second time?
Exactly. That is a major flaw, which is why researchers use alternate form reliability. So instead of giving the exact same test twice, you create 2 different versions of the test form A and form B.
Ah, I see.
Yeah, so if the scores on form A match the scores on form B, you've successfully bypassed the memorization problem. You've achieved alternate form reliability.
Got it. Wait, there's another one in the reading, internal consistency reliability. My understanding is that this is about all the questions on a single test kind of rowing in the same direction.
Yes, exactly that.
So if you're taking an anxiety questionnaire and you say true to having a dry mouth in stressful situations, you should probably also say true to having muscle tension. The items need to correlate.
Right.
Because if half the questions point to anxiety and the other half point to extreme calm, the test lacks internal consistency.
That's a great way to visualize it. But perhaps the most crucial one for clinical settings is inter-rater reliability. This measures the degree to which 2 independent observers or judges agree.
Oh yeah, the textbook uses that classic baseball analogy for this.
Right. If the home plate umpire and the third base umpire disagree on whether a line drive is fair or foul, that is bad inter-rater reliability.
Yeah, I actually think of it like asking Apple Maps and Google Maps for directions to the exact same restaurant. If Apple says turn left and Google says you are currently swimming in the ocean,
your inter-rater reliability is complete trash.
Exactly. In psychology, if you go to 2 different clinicians with the exact same symptoms, they need to arrive at the same diagnosis.
Which is incredibly hard to achieve, as we'll discuss later. But let's bring it back to validity of the bullseye. Does the test measure what it claims to measure?
Right.
So content validity is about whether the test covers the whole scope of the issue. Like if you design a test to measure life stress, but you entirely leave out questions about financial problems or physical illness, your test has poor content validity.
Because you just missed half the picture.
Exactly. And then criterion validity evaluates if your measure is associated in an expected way with some other real-world outcome or criterion.
Like an SAT score?
Yeah, perfect example. If a college entrance exam claims to measure academic readiness, it better accurately predict future college GPA. If it can, it has strong predictive criterion validity.
But the big hurdle, however, is construct validity. This happens when you're trying to measure something that isn't a physical object, a construct.
Right, things like anxiousness or distorted cognition.
Yeah, you can't just put anxiousness on a table and measure it with a ruler.
So how do you know your self-report questionnaire is actually capturing that invisible construct?
Well, it requires an overwhelming amount of circumstantial evidence. If your new anxiety test really measures anxiety, then people who are already clinically diagnosed with an anxiety disorder should score way higher on it than a control group,
Oh, that makes sense.
and their scores should drop after a few months of successful therapy. Construct validation isn't just a single mathematical equation. It's about testing an entire psychological theory over time.
Wow. There's also case validity, which I found really interesting. It asks if your interpretations are valid for a particular person in their specific, unique life context, rather than just abstract traits.
It grounds the math back into the human being sitting right across from you.
Exactly. So if those are the theoretical rules of measurement, the math and the logic, how do we actually gather the data?
Well, if people lie or hide things or simply lack self-awareness, how do clinicians measure their minds? Let's open the assessment toolkit.
Yes. The most universal tool is the clinical interview. But there is a massive operational difference between an unstructured interview and a structured one.
Right. An unstructured interview is what most people picture from movies. It's conversational.
Right. The clinician follows the client's lead, asking open-ended questions. I think of it as a blank canvas where the therapist and client paint the picture together.
But the problem is it relies heavily on the clinician's subjective intuition. Two different therapists might ask totally different questions, focus on different traumas, and end up with completely different diagnoses.
Yeah. The inter-rater reliability is notoriously low.
Exactly. So to fix that, researchers developed structured interviews. The most famous one is the SCID, the Structured Clinical Interview for DSM-5 disorders.
Right. And if the unstructured interview is a blank canvas, the structured interview is a rigid multiple-choice scantron. It's a branching interview.
The branching mechanism is the key. In the SCID, the client's response to one question strictly dictates the next move.
Oh, how so?
Well, if the clinician asks, have you ever been bothered by thoughts that don't make sense to you? And you say no, the manual explicitly instructs the clinician to skip the entire section on obsessive-compulsive disorders and move to a totally different topic.
Wow.
Yeah, it standardizes the data collection so that every single patient gets the same baseline evaluation.
If you're listening to this and thinking, wait, my therapist just asked me how my week was, she didn't use a branching scantron, you're not alone.
Yeah, the reality of private practice often looks very different from these rigorous clinical research tools. Most everyday therapists use a semi-structured or unstructured approach to build rapport.
But besides interviews, clinicians use personality inventories. And the absolute heavyweight champion here is the MMPI, the Minnesota Multiphasic Personality Inventory.
It is a behemoth. Hundreds of true false statements about yourself, making it the most researched psychological test in the United States.
The history of the MMPI is wild, though. It was originally developed in the early 1940s, and by 1989, they had to tear it down and completely revamp it.
Wait, really? Why?
Because the original version was standardized on a tiny, non-representative sample of mostly white people from rural Minnesota. And the questions themselves were deeply problematic.
Oh, no.
Yeah. They were filled with sexist wording, outmoded idioms, intrusive questions about bowel functions, and strange inquiries about excessive religiosity.
What's fascinating here is how the MMPI acts as a mirror for the evolving moral and cultural standards of society. I mean, even today, the MMPI has clinical scales that essentially measure a person's relationship to morality.
Really? Like what?
For instance, Scale 7 is psychasthenia, which measures being overly moralistic, full of self-doubts, and obsessive. Contrast that with Scale 4, psychopathy, which measures a total lack of concern for social mores and a tendency toward irresponsibility and rebellion.
Okay, wait, I have to push back on that. How is being overly moralistic a clinical medical symptom? Isn't that just a personality quirk? Or maybe a religious devotion? Like,
My-
who decides that strictly adhering to a moral code is a sign of psychopathology?
And that is the exact tension the textbook highlights. The line between a clinical symptom and a moral feeling, or a moral virtue, is entirely dependent on how the dominant culture views the behavior. The test designers are baking their own cultural norms into the scoring system.
Wow. Well, here is a memory trick for the exam. The MMPI is multiphasic because it detects multiple psychological phases or problems, but I like to imagine a test with multiple phases trying to catch you in a lie.
Oh, I like that.
Yeah, because the MMPI actually has built-in validity scales like the lie scale. It is actively trying to outsmart you.
The mechanics of the lie scale are brilliant. The test will include a statement like, I get angry sometimes, or I have never told a lie.
Mm-hmm.
If you answer false to getting angry, or true to never lying, the test flags you. Why? Because literally every human being gets angry sometimes, and everyone is told a lie.
Exactly.
If you claim otherwise, the test assumes you're faking good to look socially desirable, and it mathematically adjusts your other scores to account for your defensiveness.
So if the MMPI is trying to catch you in a lie through objective true-false questions, what if we just bypass your conscious lying brain entirely?
Oh, right.
That brings us to projective tests, like the famous Rorschach ink blots.
The ink blots are deeply rooted in the psychoanalytic paradigm. We need to define that. It's essentially the old-school Freudian idea that human beings have a hidden basement in our minds, the unconscious, where we lock away our darkest urges, repressed traumas, and unacceptable fears.
It's the ultimate cloud watching of psychology. The projective hypothesis assumes that if I show you an ambiguous, meaningless image, just a symmetrical splatter of ink, your conscious brain doesn't know what the right answer is.
Your filter just drops.
Right. And without realizing it, you will project whatever is hiding in your mental basement onto the image. If you see a beautiful butterfly, maybe you're well-adjusted. If you see a monster tearing someone apart, maybe we have something to talk about.
The theory is poetic, but the reliability and validity of ink blots are fiercely debated. I mean, how does the clinician objectively score a monster versus a butterfly?
Yeah, you really can't.
Exactly. So to escape that subjectivity, modern clinicians are increasingly turning to biological assessments.
Yeah, the textbook lists a bunch of acronyms here: fMRI, PE scans, EEGs. But how do these actually help diagnose a psychological issue versus a neurological one?
They look at the physical mechanics of the brain. An EEG, or electroencephalogram, measures the electrical waves sweeping across your scalp. It can tell us if a patient's brain is firing in patterns consistent with epilepsy or certain sleep disorders.
Okay, and what about an fMRI?
An fMRI, on the other hand, doesn't just take a static picture of your brain, it measures function. Active neurons need oxygen. So an fMRI tracks the blood flow, bringing oxygen to different regions of the brain in real time.
Oh, wow.
Yeah. If a patient is shown a scary image, the fMRI can actually watch the amygdala, the brain's fear center, light up with increased blood flow.
So a clinician gathers all this massive, messy data. They have the structured interview scantrons, the true-false MMPI profiles, maybe an fMRI scan showing blood flow. Now they've had to synthesize it all into a single diagnosis.
And that brings us to the ultimate rulebook, the DSM-5.
Right. The Diagnostic and Statistical Manual of Mental Disorders. Diagnosis matters for three pragmatic reasons. First, professional communication. If a psychologist in Toronto says a patient has major depressive disorder, a psychiatrist in London needs to know exactly what cluster of symptoms that implies.
Makes sense. Second is that it guides treatment. Certain therapies are empirically proven to work for specific disorders.
And third, the unspoken reality insurance billing.
Right.
In most modern healthcare systems, if you do not have a DSM code to put on the paperwork, you do not get your treatment paid for. But the way the DSM classifies these disorders has been undergoing a massive philosophical shift.
Let's use a lighting analogy for this.
Yeah.
Historically, the DSM used a categorical classification system. Think of a standard light switch. You flip it on or you flip it off.
Yeah.
You either have schizophrenia or you do not. You either have major depression or you are fine.
But the problem is, human suffering rarely fits into perfectly neat binary boxes,
Right.
which is why there's a massive push toward dimensional classification. Think of a dimmer switch. We all experience some level of anxiety. It is just a matter of how bright the bulb is glowing on a scale of 1 to 10.
Yeah, a dimensional approach allows us to see the continuity between normal behavior and abnormal behavior. The DSM-5 tried to introduce more of these dimmer switches, adding dimensional severity ratings, mild, moderate, severe, into the manual.
It is a vital shift because it acknowledges that psychopathology is often a matter of degree. But here's where it gets really interesting. If the DSM is the supposedly rigorous scientific biological rulebook, why is it constantly surrounded by intense public controversy?
Yeah,
Every single time a new edition is published, there are massive debates, protests, and op-eds.
because it's not a pure biological rulebook. It's written by committees of human beings. It's heavily influenced by shifting cultural norms, financial pressures, and it faces intense moral scrutiny. Let's slow down and look at a few of the fierce debates surrounding the release of the DSM-5.
Okay, yeah. One of the biggest cultural earthquakes was the elimination of Asperger's syndrome. In the older DSM-IV, Asperger's was a distinct diagnosis for individuals with social difficulties but normal language and intelligence.
But in the DSM-5, the committee erased it. They subsumed it into the broader dimensional category of autism spectrum disorder.
Right.
The clinical rationale was that researchers simply couldn't reliably differentiate Asperger's from high-functioning autism, so they merged them.
But that purely clinical decision caused a public uproar. People who strongly identified with the Asperger's label felt their identity and community were being erased by a textbook committee.
Yeah, and furthermore, parents were terrified that without the specific Asperger's label, their kids would lose access to specialized educational services.
It's a stark reminder that diagnostic labels are not just medical jargon. They're deeply woven into people's personal lives and legal rights.
Absolutely. Another massive controversy is the creation of a brand new disorder called disruptive mood dysregulation disorder, or DMDD, for children.
What are the criteria for that?
Well, they involve severe temper tantrums that are completely out of proportion to the situation, occurring 3 or more times a week.
Okay.
The intention behind creating DMDD was actually a protective one. Clinicians were noticing an alarming trend. Children with severe mood swings were increasingly being misdiagnosed with bipolar disorder.
Oh, wow.
Yeah, and as a result, these kids were being prescribed heavy antipsychotic medications with serious side effects. DMDD was meant to provide a more accurate, less severe label to stop the overmedication of children.
But critics immediately mocked it as the temper tantrum disorder. They argued that we are simply pathologizing normal, albeit frustrating childhood behavior.
Right.
Like if a 7-year-old throws a massive fit because they can't have ice cream, is that a psychiatric disorder or are they just being a 7-year-old? By creating this category, we run the risk of artificially inflating the number of children labeled as mentally ill.
This raises an important question about the line between normal human suffering and psychopathology. And nowhere is that line blurrier or more ethically fraught than in the debate over the bereavement exclusion.
Oh, this one is heavy. Let's paint the picture for you. Imagine you lose your spouse of 40 years. 2 weeks later, you exhibit all the classic symptoms of major depressive disorder. You cannot sleep, you're crying constantly, you've lost your appetite, you feel an overwhelming emptiness.
Right.
Under the old rules of the DSM-IV, there was a specific clause called the bereavement exclusion. A doctor was instructed to say, you are grieving. This is a normal human reaction to profound loss. Take time.
Yeah.
You could not be diagnosed with clinical depression for the first 2 months.
But the DSM-5 committee removed that exclusion entirely. Now, under the new rules, if you meet the criteria for major depression just 2 weeks after a loved one dies, a doctor can officially diagnose you with major depressive disorder. The clinical rationale is that severe grief can trigger a genuine major depressive episode. And withholding medical treatment or therapy from someone who's acutely suffering simply isn't ethically right.
But the pushback from both inside and outside the psychological community was immense. I mean, the argument is, are we pathologizing the human soul? Is it a medical disorder to mourn deeply for someone you loved?
Yeah, it feels like we are taking a profound moral, spiritual, and universal human experience grief and just slapping a clinical barcode on it.
Exactly. Critics warned that we are placing an arbitrary timeline on mourning and potentially handing out pills for something that just requires time, community, and support.
It highlights the sheer power the DSM has in defining what society considers normal. And this brings us to the vital role of culture and spirituality in assessment. Our textbook features a fascinating vignette that perfectly illustrates this.
Oh, the one about the Haitian girl.
Yes. It involves a 16-year-old Haitian girl who was brought to a Western hospital presenting with symptoms of disorganized schizophrenia hallucinations, erratic behavior, severe withdrawal.
Her clinical medical team looked at her and saw a biological psychiatric illness requiring heavy antipsychotic medication. But her family, and a traditional healer they consulted from their community, viewed her illness through an entirely different lens.
Right. They believed her condition was caused by an ancestor's spirit in her mother's family who had been offended.
To the Western medical team, it was a brain dysfunction. To the family, it was a spiritual and religious issue that required restoring moral cohesion and respect in the extended family.
And here's the crucial part. The traditional spiritual interpretation wasn't just a superstition to be ignored. It actually helped the family rally around the girl. It broke their sense of shame and isolation, which ultimately allowed them to build a trusting alliance with the medical team.
It proves that you cannot assess a patient in a vacuum. You have to understand their cultural and spiritual worldview. And to be fair, the DSM-5 actually made huge strides here by introducing the Cultural Formulation Interview, or the CFI.
The CFI is a semi-structured interview tool that clinicians can use to intentionally bridge the gap between rigid Western clinical definitions and a patient's own cultural perspective.
Right.
It prompts the clinician to ask the patient directly, how does your culture define this problem? What do your family and friends think is causing this? How do people in your religious background cope with this kind of suffering?
Yeah, it's a formal recognition that mental health is inextricably linked to cultural context. So what does this all mean? We've covered a massive amount of ground in this study session.
We really have.
We started with the foundational mathematical rules of measurement, knowing the difference between a highly reliable 500-pound broken scale and a valid test that hits the bullseye. We unpacked the clinician's toolkit from the branching Scantron questions of the SCID to the morality scales of the MMPI to the blood flow tracking of an fMRI. And finally, we explored the ultimate, albeit deeply flawed classification rulebook, the DSM-5.
And if there's one thing for you, the learner, to take away from all of this, it's that diagnostic labels carry immense life-altering power. For many people, finally receiving a diagnosis is a moment of profound relief.
Yeah.
It puts a name to their suffering, it connects them with a community of people who understand, and it unlocks access to life-saving treatment. But those same labels can also carry heavy stigma.
They really can.
They have the potential to pathologize normal variations in human behavior, childhood development, or even grief. Understanding how these tests are built and how these labels are debated and decided upon empowers you. Whether you're a patient navigating the system, a future mental health professional, or just an informed citizen, you need to know that these categories are not handed down from a mountaintop. They are constructed by humans.
Which leaves us with a lingering thought to chew on before our next deep dive into the source material. If our diagnostic manuals are constantly evolving, and what was considered a profound spiritual experience or a moral failing a century ago is now classified as a psychiatric symptom today, what will today's diagnoses look like to undergrad psychology students sitting in a study session 50 years from now? Will they look back at our DSM-5 and think we were trying to read that broken X-ray machine upside down?
It's entirely possible. I mean, the muddy waters are always shifting, and the definitions of normal are always being rewritten.
Thanks for studying with us. Catch you next time on the Psychology Undergrad.